and welcome to another UOS ONG revision video. This video will focus on amenorrhea. Firstly, amenorrhea can be split into primary amenorrhea. This is a failure to menstruate before the age of 16 years old. And you have secondary amenorrhea. This is a cessation of menses for 6 months or longer. This video will mostly focus on secondary amenorrhea. Secondary amenorrhea can be split into disorders of the hypothalamus, disorders of the anterior pituitary, and finally disorders of the ovaries. We will now focus on disorders of the hypothalamus. This is usually due to a 10 to 15% weight loss, which results in a deficiency in GnRH production by the hypothalamus. As a result, you get a decrease in FSH and LH production by the anterior pituitary, but prolactin levels are usually normal. The weight loss is usually due to an excess in exercise or a decrease in nutritional intake due to anorexia nervosa, for example. We will now move on to disorders of the pituitary. An example is a pituitary adenoma. This is a tumour of the anterior pituitary, which results in an increase in prolactin production. Prolactin then inhibits GnRH production by the hypothalamus. Another disorder is Sheehan syndrome. This is necrosis postpartum of the pituitary. Antidopaminergic drugs can also impact the pituitary gland. We will now move on to disorders of the ovaries. Firstly, you can get premature ovarian failure. This is an autoimmune condition which results in premature menopause before the age of 40. Another condition is PCOS, more commonly known as polycystic ovary syndrome. The Rotterdam criteria tells us that in order to diagnose PCOS, women must have 2 out of 3 of these conditions: anovulation, signs of hyperandrogenism such as acne, hirsutism, or obesity, and finally 12 or more follicles in one or both of the ovaries diagnosed via ultrasound. So what is the pathophysiology of PCOS? Well, firstly, in the ovary you have follicles. These follicles are composed of theca cells on the outside and granulosa cells on the inside. In PCOS, you have an increase in LH production by the anterior pituitary. This results in theca cells producing an excess amount of testosterone. In comparison, you have a relatively lower amount of FSH production by the anterior pituitary, and as a result, this results in a decrease in estrogen production by granulosa cells. Decreased estrogen results in no LH surge, which you would normally get in normal menstruation, and as a result, you don't get ovulation. So how do we diagnose PCOS? Well, usually via transvaginal ultrasound scan. The LH to FSH ratio would be increased, the total testosterone could be increased, the prolactin levels may be normal, and TSH levels may be decreased. How do we manage PCOS? Well, usually conservatively through lifestyle, a healthy diet and exercise. The amenorrhea can be managed medically via the combined pill Mirena coil or progestogens. The hirsutism can be managed conservatively or medically. Medically via spironolactone and conservatively via mechanical shaving, for example. And the anovulatory infertility can be managed either conservatively through weight loss or medically via clomiphene citrate or via gonadotrophins. Another method is via ovarian drilling. So thank you for watching this YouTube video. If you enjoyed this video, then please subscribe to our YouTube channel and like this video.